Hey everyone, my name is Jennifer Abdul Rahman, and I had chapter 16 in the book, which was staffing and scheduling. I found this quote about staffing, and it says there's a correlation between nurse staffing ratios and adverse events that occur in hospitals that are related to nursing care. And essentially, it's saying how important proper staffing is because if we don't staff our units properly and a nurse has too many patients to handle, there's more likely a chance that she is going to make a med error, have a sentinel event, or have something bad happen to her patients. Whereas the more staff we have and the more properly staffed we are, the less likely these things are to happen. And it can affect all quality control issues such as falls, pressure ulcers, hospital acquired infections, everything. Sullivan defines staffing as the goal for staffing is to provide the appropriate numbers and mix of nurse and staff. So a mix of nurse and staff is LPNs, RNs, unlicensed personnel, to which is essentially nursing care hours. It goes by nursing care hours to determine how many of these personnel we need, and also match it to actual or projected patient care needs. So depending on the type of staffing that your unit does, you're either looking at the actual hours, which means you're doing short-term staffing, or you're looking at projected patient care needs, and you're doing more of a long-term staffing. And the way they determine that is by patient care hours. Essentially, how many hours does it take to care for a single patient, and then there's actually a formula to figure out from there how many hours you need for the entire unit. And all this is to provide effective and efficient nursing care. And the ANA and the Joint Commission, they actually have requirements outlined in regards to staffing, because each unit, each facility, their staffing needs vary between facilities and units, and even the day of the week could determine a different staffing need. So the requirements that the ANA and the Joint Commission have is that there should be input from direct care RNs. So you want to ask your staff who's working on the floor what they think, because they're the ones that know their patients and know what the acuity is, and know what the unit needs. And then you're also looking at the number of patients, the patient acuity, how many discharges and admissions there are, how many transfers there are on that shift, to determine how much staff you need to cover the patient care for that shift. You're also looking at the level of expertise of those providing the care. So if you have newer nurses on the floor who maybe can't handle as large of a section as more experienced nurses, that needs to be taken into consideration, because they actually do have a requirement that says an RN should not be forced to work on a unit if she does not feel that she can provide professional care to the patients. So I think that's really important for everyone to be knowledgeable of, about what your staff is capable of doing and the care that they're capable of providing. And management should really be communicating that to those who are going to be charge nurses, because you don't want to put somebody in a position where they feel uncomfortable or give them more than they can handle, because it will affect the patient care adversely. And also, staffing levels are recommended by specialty organizations such as the ANA and the Joint Commission. So these are different definitions that were in the book regarding staffing, and also different types of staffing. So patient classification system, or also referred to as the PCS, it also goes by patient acuity systems, and it uses patient needs to objectively determine the workload requirements and the staffing needs for a unit. So the patient classification data is actually analyzed mid-shift every shift to determine the staffing needs before the next shift arrives, so that adjustments can be made. So if you're looking at, 7 to 3, 3 to 11, around 11 or noon, you want to start looking at your unit and see what's going on your unit, and do I need all of my 3 to 11 staff, or do I need more 3 to 11 staff, so that you can make adjustments so that the unit is properly staffed. It sounds like an ideal situation, but it really only works if everything goes right. The negative part of this type of staffing is that if someone calls out sick, especially at the last minute, or patients are transferred off the unit or transferred onto the unit, or you have incoming nurses that maybe can't manage a higher patient ratio, then that creates a problem, and usually last minute decisions need to be made as to, acquiring more staff. Either calling people and begging people to come into work, or using the float pool if there's people available from float pool. Some argue that basing staffing on immediate needs doesn't always work out so well. And that's where demand management comes in. Demand management uses protocols to predict and control the demand for nurses based on patient outcomes. So you're actually able to staff a unit a few days in advance rather than doing it shift to shift. And they do it based on trends of expected patient outcomes. So if you work on a unit where you can easily predict what the patient outcomes are going to be, such as maybe labor and delivery. Maybe you have a set amount of C-sections scheduled that day, and you can trend how many vaginal deliveries you're going to have that day, and maybe you can also trend how many emergency C-sections your unit typically has. Now you can kind of staff ahead of time based on those numbers. And once a system is determined, then they look at nursing care hours, or NCH. And nursing care hours is, it can vary from unit to unit depending on the acuity of the patients. And essentially, it's how many hours does it take a nurse to care for a patient. So depending on if you work in intensive care or critical care, it's going to take you twice as long to care for a patient as maybe one who is on a rehab floor. It's going to take less time. So that's what nursing care hours is referring to. And in order to determine nursing care hours, you also have to know patient care hours. You need to know how many patient care hours you have on your entire unit to be able to staff for the nursing care hours. And there's actually some formulas that I'm going to go into a little bit later on how to find those numbers. And actually, in addition to that, through some of the research I found, and actually we do it on our unit too, all that information is supposed to be public knowledge. So once you determine what your nursing care hours are during the day and what your patient care hours are, that information actually has to be posted on the unit where residents, or like where the patients and family members and everything can see that information. And the way that you figure out if you're actually looking at like nursing hours per patient per day, that's determined by taking the nursing care hours and dividing it by the total census. And then you get, you essentially get an average of the number of patients on that unit for that day. And I actually wanted, the book actually has a chart that explains this really well, so I wanted to go to that for a second, because it's kind of hard to explain without having a visual. But essentially, say that you have 26 patients on your unit, and they usually determined by acuity level how many hours of care that patient needs. So they split up the 26 patients. They have 3 patients at a level 1 acuity, 10 at a level 2, 11 at a level 3, and then 2 patients at a level 4 acuity. And they've determined that for the 3 at the acuity level 1, it takes 6 hours to care for those patients. 60 to care for these 10, 77 to care for these 11, and 18 hours to care for these 2. So that comes out to 161 total hours of care for that 24-hour time period for these 26 patients. And then to figure out the average nursing care hours per patient per day, you divide 161 by 26 and you get 6.19. So it takes 6.19 nursing hours per patient per day, which is required. So that's how you get these numbers. And the 161 is the total hours of care or nursing care hours. So that's that chart for that portion of it. And then additionally, I'm going to go into full-time equivalent on the next slide, but using full-time equivalent, they base it off a 40-hour work week, and most places will do a schedule based on every 2 weeks. So it's actually 80 hours per two weeks. And then they figure out that it's 2,080 hours per year based on the 40-hour work week per week for 52 weeks. And then you can either use like one person to fill the slot for the 40 hours, or you can use a combination of people. Like if you have maybe 3 different people, and one's working 24 hours that week, another's working 8 hours, and another's working 8 hours. That's 3 part-timers that you can use to fill the 40-hour work week slot, or you can use one person to fill the 40-hour work week. And that actually goes into full-time equivalents. If you ever noticed, like on your job description or maybe your paycheck, it might mention it. It lists your position as a 0.4 or a 0.6 or a 0.8. Or you're a 2.1 or a 2.4, that's a full-time equivalent, because it's not necessarily one staff member that equals a full-time equivalent. It's your nursing care hours that equals a full-time equivalent. So if you're a 0.4, you might have to match up with a 0.6 so that they can get in, like a 40-hour work week. So that's kind of how that portion of it works, and there's actually a lot of math that's involved with that, and I'm going to show some equations then on how they actually determine those numbers. Another type of staffing is actually block scheduling, and they use this more so in like the ED or maybe labor and delivery. And this type of staffing, they block out certain parts of the day where they know that there's going to be peak workload hours. Like some of the literature I was reading said specifically for the ED, like 5 p.m. to 9 p.m. is a peak workload because it's after the doctor's office is closed. Or like 1 to 4 in the morning is peak workload because everyone's leaving the bars and they're intoxicated, and that's when you have a lot of car accidents or just unruly people that are brought in to detox. So those time slots, they usually have more staff working so that they can cover the extra workload. So it works really well on units like that where you have certain time slots where there's going to be a heavier workload.